Rarer cancers were mentioned just then. That's what our next question from Nicola Davies is about. Nicola.
Very interesting to hear you point out, because it does lead really well onto this question. The government has stated that it's committed to improving survival rates from cancer, with a target saving an additional 5,000 lives per year. 53% of UK cancer deaths are actually from less common cancers, including sarcoma. Sarcoma survival figures haven't improved in the past 20 years, and still only around 50% of sarcoma patients survive for 5 years. Yet there is evidence that early diagnosis, my sarcoma specialist centre, can improve survival. What does the panel think needs to be done to improve the awareness and education of GPs and other healthcare professionals to ensure people with rare cancers get the appropriate support they need from specialists a lot quicker?
Jane? Yeah, I'm sorry, but it must be.
Okay, well, so I think there's three things here. I think the first thing is really learning from the sarcoma groups, from the self-help groups about rarer cancers, because I think the 52 group and the other, rarer cancer groups have an enormous amount to contribute in actually identifying where things went wrong. I also think, funnily enough, the patient experience survey, the National Patient Experience Survey, looked at asked questions of groups of a huge number of cancer patients, and they included a whole load of questions about how many times you saw your GP before you were actually diagnosed. And there were a lot of qualitative comments associated with that, which can be fed back at a local area, so that those areas where there's been late diagnosis, it can be looked at and you can do proper significant event analysis. So I think there's quite a lot of value in using that data to really feed back locally. I think the third thing is developing some really good tools that you can use in the surgery. If somebody comes with this and this, which is very rare, it should just throw up a signal. And quite often, I think it's the multiple visits which is very important. Which is, if somebody who is young and fit comes more than twice with something funny, it probably should throw up a signal. I don't think you're ever going to have, a foolproof thing for a rare condition. But I think listening to the patients, learning from the patient experience survey, significant event analysis can all make a real difference.
Anybody want to comment on that?
I think Jane's absolutely right, and I would really emphasise the value of research, because,
yes.
And especially now, there's so much more data in the system now. Over the last 10 years, there's been a massive improvement in the data that's available. So going back and reviewing case notes and so on, these are all the kind of studies that can be done. And I think that again, we need to get the indicators in the system, and the rarer cancers, survival outcome measures for all cancers will now be part of the outcomes framework, and that's so important because, as you say, the majority of cancer deaths do fall into the less common cancer groups, and there's a lot to learn from the experience of breast cancer, where the early signs of breast cancer are well understood. 9 out of 10 breast lumps are not cancer, but still, if you go to your GP with a breast lump, the GP will most likely want to rule out cancer. And so, for example, in pancreatic cancer, we were talking about only the other day again, the idea there that perhaps what people should be doing, if you've got people coming with gastric reflux and so on, that they should be ruling out the possibility of cancer. And again, we need more research for better, cheaper, more efficient tests, so that they can be used more systematically and more commonly.
Judith.
Yeah, can I just say something about rarer cancers in general, and not specific? One of the really good news stories that came out of the last health bill was the fact that rarer conditions won't be commissioned by the GP commissioning groups. They won't be commissioned locally. They're going to be commissioned by experts, so that if you have a rare cancer, for example, you will get the same sort of service right across the country. So that is really, really good news. It won't be a fragmented service, and it will be expertly commissioned, not necessarily from the centre, but by somebody who has got a really good grasp of what's available right across the country.
So you go to your doctor in Croydon,
yeah,
and you'll be referred to the best nearest centre for that cancer.
Effectively, yes, that's right. They won't be commissioned by what's your local commissioning group.
Right.
Can I just very briefly?
Yeah.
I know. Is there any GP here, sitting in the audience?
They're doing their jobs.
Yeah, they're doing the job. I was going to question whether they should be here or there. One thing which, with my own experience, I would say that because all the GPs are not aware of the symptoms of every cancer, unless you're getting a lot of patients coming with that experience to immediately judge. If somebody only going once in a 10 years GP's experience, one person, John, that's where it's a delay, because the GP will see those symptoms in a different standpoint. GP will see that is it a cold, then is it headache is because of flu, or something else in it, unless they have the experience. So I think the fear is that how much information the GP is getting on all the cancers and the symptoms, and how much they read and they get that information. I'm not going to go in details on that. I just put this question back to say that because of GPs not getting those patients on a regular daily basis, then there was sometimes not immediate knowledge of that, and that's where the delay is, to referring them to the specialist or the experts, taking where it should be today, might take 3 months before somebody else comes and say, look, do you know it happened in Croydon, not in Ealing?
Okay, thank you very much. Well, now Derek Stewart. Oh, sorry.
Can I just ask one question on that?
Yeah.
The human papillomavirus in men and boys, we currently vaccinate all girls at the age of 12. We don't vaccinate boys. Yet it's been proven in the States that if we vaccinate all boys, then the rates go down, which then saves the government money. I just want to ask the panel if there's anyone talk about getting boys vaccinated, and if not, why not? And is it just because of the money side, or is it because it's political?
It should be clinical rather than political, but I'm not aware of that.
My understanding was that the evidence wasn't there. I mean, if you want to drop me an email, then...
The evidence is there now.
Because we asked a question about it, it came up really quite recently, and we were told that the evidence wasn't there yet to vaccinate boys as well as girls. Okay.
The thought that the US health system is in some way managing to do something that we're not is a modern miracle.
They've just switched over now, and they've vaccinated all
Seeing as
boys
60 million people in America don't have any health care at all. Anyway, that's an interesting question. It might be well worth chasing with
do
Judith.
Drop me an email,
Yeah.